Welcome everyone. Sorry to be just a moment late in starting up today. I'm sure that everybody will be joining in. And I will ask you, as you're coming in, if you can, let us know who you are and open up the chat. And please let us know who you are, open up the chat, introduce yourself, and here we go. Welcome, Helen Lung, Mike Heinmarsh, Trudy DeVries. Really nice to see people joining in here now. And I know that we have about 150 people, so we should start seeing some names coming in. Deborah Krause from Charlotte Lake Family Health Team, welcome. Nila Brown, Wenda Jerry, nice to see you. Sandra Fitzpatrick, welcome. Let us know where you're coming from. Megan from Ontario Health, nice to see you. Welcome everybody, coming from all corners of the province today to join us in today's event, today's webinar. Please open that chat box. Make sure that you have clicked on everyone so that everyone can know the people who have joined us here today for the event, for the webinar. And please make sure that everyone is also enabled throughout the conversation today, as we are all very keen to learn what each other are doing and where each other are coming from. Welcome to Sarah Cohen from Toronto Public Health, and Olga McNeil, welcome. Janet Durbin, Kem H, Ivanip, Mi Hong, welcome. Keep joining in, please sign in and let us know who you are by checking in on that chat box. Really liking having everyone participating again here today. We have a really interesting opening today of a series that we're going to bring. But I want to begin always by acknowledging the land. I'm speaking to you today from the University of Toronto, and for thousands of years, it's been the traditional land of the Huron, Wendat, the Seneca, and the Mississaugas of the Credit. Today, it's the meeting place still and home to many Indigenous peoples from across Turtle Island. And I am grateful to have the opportunity to work on this land and to host you from here. Please take a moment to acknowledge the land that you are speaking from and its history prior to colonization. We're going to kick off here with a quick little poll and see, because we are getting, and as our topics change, I think sometimes we get some new audiences occasionally. So for the first time, I want to know if this is your first time joining us. So if you could just let us know if it's the first time you've joined us. And this poll isn't showing, so I'm going to ask for our other colleagues, Nusrat or oh, there we go. Thank you very much. Appreciate that popping in that poll. And I see everybody now is clicking in, almost everybody, whether if you've joined us previously or know this is your first event. And we have most of the people have participated now. We'll leave it out just another minute or two to track on this. And yeah, popcorn has definitely slowed. So I will ask our trustee colleagues to share the results out now. And we see amazing. This is, I think, something near our 20th event. And 70% have joined us previously, and 30% just saw this piece on equity and they said, hey, that looks very interesting. I'm going to check in for that. So welcome. It's your first time. Later on, you'll see all of the events that we've posted previously, and you can go back and see some of the prior ones at your leisure. So really excited to see so many new people again joining us. Today it's Dr. Paul Wonka and myself, Dr. Walter Wojcik, and we are here from the Health System Performance Network to start our discussion on equity. And this isn't really the very beginning. If you've been following us along, you know that we've mentioned equity in almost every single one of our events along the way. But we're going to have a little bit of an emphasis in the next little series for several reasons. But mainly, I want to start us off by thinking about, how do we go about really thinking about equity and making a change happen? So we can't do all of this in one event. So today we've decided we're going to start off on a primer. Dr. Paul Wanka is here on a postdoctoral fellowship, and his emphasis is actually in understanding how Ontario health teams and integrated care programs in general address issues related to equity. So he's going to start us off with some of the ways we can be thinking about this. And then I'm going to, for this primer session, bring in a number of the data points that we've already shared with you. So we're going to look at it from a data perspective of how have we been measuring from the Health System Performance Network equity over time through all the dimensions of the quadruple aim. And so we're going to come back to that. I want to just start off with a little bit of a poll to get a sense of people where you have been focused and what your Ontario Health teams, or if you're not in an Ontario Health team, whatever your background might be, where you've focused your efforts in relation to equity. And I'm pretty sure you should be able to check on multiple boxes here and click in, hit submit, and we'll be watching to see what you have been doing already and get a bit of a sense, because we know that some of these are activities that everybody has been doing. There is an option for other. We're interested in knowing if you're doing other things as well. And so please pop into the chat once you've answered the poll here, what the other things are, and then we can explore those a little bit further across the webinar. So people are clicking in there. It takes a little longer because there are many, you can have multiple options here. So we'll leave it open a little bit longer for people to have that opportunity to enter what your activities have been. I know one of the things I had just mentioned, and we can visit this and revisit it a couple of times, is that one of the things I said is that we're going to talk about how we've been measuring equity across the quadruple aim, and we haven't specifically moved to what some people and some of the Ontario health teams have moved to a quintuple aim. And part of that is that we don't want to have equity as something different, and we want to make sure that we're embedding it in everything that we do. And this is our approach to doing that, is to make sure that when we think about measurement, we make sure that we think about the ways we should and can be measuring equity in all of our areas. Okay, the poll slowed down now, so I'll just ask our team to share it up. Appreciate that. And I see that we did have the at least a few other options, and someone had put in to the chat here, they're addressing health equity as it relates to the Ontario Public Health Standards. So I think that that's really interesting. And Trudy DeVries at the ML-OHT, Middlesex Lambton, I want to say, creating an EDI collaborative to allow the leads of organizations who carry out the EDI work to come together and share their work. Well, I think that's fantastic. That's going to be something we bring up a little bit along the way. So let's have a look and see what people have been doing. So a couple of groups don't yet have, not very many, it's the minority, a specific activity relating to equity. And then the next lowest is actually using equity data. So that makes me very happy that we've organized today's event the way we have, and we're going to come back to data again in the future. Almost half of an equity working group, half are training staff, and about half again using equity data about your population. That really warms my heart, because I like to hear people doing that. Okay, we can take that down, and I think we're going to start off now by turning it over to Paul to lead us through some of his work and how we can and should be thinking about equity as it relates to Ontario health teams. So Paul, I'll pass it over to you.
Yes, thank you, Walter. Yes, can you pass to the next slide? Yeah, the first one. The previous slide, please. Thank you.
This one.
Yes, yeah. So I will start, thank you everyone for joining us in this webinar. So I will start by like a brief background. It's like Following the introduction of the Connecting Care Act of 2019, OHTs were introduced as an innovative model that focused on enhancing collaborations between different provider organizations in the continuum of care in different population groups. And this was to ensure like better connectivity of care that is for individuals and communities. And like most integrated care systems around the world, OHTs have progressively implemented key enablers like collaborative governance models, leveraging digital health in order to enhance interorganizational communications or interprofessional team-based care that will also improve coordination of care across organizational boundaries. And all of these enablers was supposed to help like OHTs carry out the activities to deliver better connected care to their populations. Next slide. So while establishing OHTs and evolving with the different enablers, next slide. Yeah. So as effective integrated care systems that at maturity will be physically and clinically responsible for the health of their populations. So systems leaders have explicitly expressed strong commitments to enhancing equity in all aspects of the organization and delivery of care across Ontario health teams. This fundamentally means a transformation in the healthcare system towards a model that consistently considers social justice and fairness in all aspects of care. So this is why this presentation would try to revisit some of the main tenets of equity and what it means for Ontario health teams. So next slide. So the first, these are all terms that we are very used to in terms of like our regular healthcare system, this like the healthcare, health equity and health inequities. So the broad definition of health would actually can be considered like the Ottawa Charter of Health Promotions really states that health is the state of complete physical, spiritual, mental, emotional, environmental, social, cultural, economic wellness of the individual, family, and the community. And health is also considered as a major resource in terms of how people can be productive members of the society and also communities in terms of managing their independence and progressing towards achieving their own specific goals. And healthcare now covers all of those aspects of health services that are really needed in order to establish these connections, like the collaborative governance, and also allocating resources according to the different needs that is necessary for the whole system to actually function effectively. So when we talk about health equity, this is much more like some sort of a normative terms that really focuses on understanding how people, like every individual within the population, has an equal opportunity to achieve their full health potential. This is extremely important because several studies have shown that within the general population, although healthcare has really improved over the last few decades, however, there are still certain groups that have poor outcomes in terms of care, poor access to the healthcare system, and also are treated differently, some sort of like discriminations that actually occur across the healthcare system. And why do this actually happen? It's just because like we have some sort of like health inequities, and these inequities are like systemic, unfair, and avoidable differences in the health of various social groups. Why are they systemic? Is because there is a consistent pattern of differences in health between people that actually have a higher, like a higher level in the social hierarchy as compared to those that are in a lower level in the social hierarchy. And then why is it unfair? It's because from a social justice and from a fairness perspective, we kind of see that there is this consistent difference, and it is also avoidable because these differences are the result of uneven distribution of resources, power, and opportunities within our societies. This means that if we decide to do something, we can actually improve or reduce the disparities between people of different social groups. Next slide. One other key concept is social class. So this social class now, this refers to different groups that's due to the differentials in the distribution of power, privilege, and prestige across societies. We have these different groups across the social hierarchy that have much more opportunities to achieve better health than other groups that have less opportunities to achieve this better health. And how do we identify these different social groups? Generally, we look through the social determinants of health, which are the conditions in which people are born, they grow, they work, they live, and they age, and that's actually have some influence on their health. So if we are actually thinking on looking at the healthcare system, these social determinants of health as identified by one of the the conferences here at York University, they actually identify 16 different social determinants of health, which are displayed on both sides of the image that we have down there. So referring to this image, we see about, let's say, 3 different people trying to watch a baseball game. And if the baseball game is actually like attaining your health, these men, their main difference is like in height. If we take disability, like a social determinant here, so the person with the taller person has no physical disabilities, for example, and the shorter person probably has maybe some physical disability. And if we are looking in terms of equity, we see that in order to improve the healthcare of the shorter person, we will need to find different ways of organizing the resources within our healthcare system in order to help, in order to distribute them according to the need of different groups, instead of doing a flat distribution equally across the different groups. So what has been done in terms of the Ontario context? Next slide. We have Ontario Health has produced guidance documents like the Equity, Inclusion, Diversity, Anti-Racism Framework in 2020 that has assisted several, that lays about 11 different strategies that you can use in order to advance health equity. And we have 4 core strategies: collecting equity data, embedding equity in the strategic plan, partnering with other organizations in order to advance indigenous health, or then they have about 7 different peripheral activities that can be used to advance some health equity. We know for sure that some organizations, for example, when we examine the Greater Hamilton Health Network Health Equity Framework, they constantly referred to the Ontario Health Equity anti-racism framework. So we would also like to hear, what are your experiences? How did you use this particular framework in your reflections and the activities that you developed to advance equity in your Ontario health teams? So next slide. So what does this mean now for Ontario health teams? We can actually look into particular areas, that is promoting Ontario health teams would definitely need to promote equity in health and healthcare in all aspects of their interventions. That is incorporating an equity lens in the organization and delivery of health services, and considerations of socially disadvantaged groups in the organization and delivery of services. So developing these interventions to reduce disparities, and also between the disadvantaged and advantaged groups, is going to be like a key process between for the Ontario health teams. And also Ontario health teams will also need to focus on how to monitor the progress in equity in the health and healthcare. That is like the ongoing assessment of patterns of health inequalities, focusing on those that are most likely to be unfair and avoidable in order to inform their practices and also to guide the development of policies that will also help to improve this, like reduce these inequities. And part of my work, I come up towards like understanding like the equity measurement strategy. That is when like the evaluation strategy of the different Ontario health teams. How do they put the special considerations in assessing the disparities between the different social groups and also incorporating it in the regular evaluation and monitoring of the healthcare system? Next slide. So the equity measurement strategy now just emerges like what is it and how do Ontario health teams how can they learn from it? So these measurement strategies would be like multiple activities that's coming together. They aim to improve the assessment of these health inequities in across this population. And for example, we can actually see this equipment measurement strategy as being part of the broader evaluation strategy. Like Ontario health teams are required to have this collaborative quality improvement plans, the CQIP, that they develop. So in integrating an equity lens in the CQIP might also be some aspects of like having a coherent equity measurement strategy. Or also they can have like separate discrete activities, for example, carrying out an anti-Black racism survey that also complements the broader equity measurement strategy. So our studies show that we have about 5 different components that are needed for an effective equity measurement strategy. Next slide. So the first is that the first component of an effective equity measurement strategy is having that capacity to identify the social groups of concerns within the population. That is, there are just so many vulnerable or disadvantaged social groups within your population. So do you actually measure all of these at the same time, or do you have some sort of way of prioritizing those that are much more relevant to your local context? That would mean that you need to engage with different social actors in order to identify what's like what are the groups within my population that are most at risk, and those that we need to urgently actually look into how the disparities between them and the other populations can actually be addressed. And also identifying the indicators of interest, because at the end of the day, when you're talking of monitoring health equity, you're actually looking at the disparities between the different social groups, and what you're going to be looking at are like how these different performance indicators in their populations, how they like do some sort of disaggregated analysis across like the different social groups to see the social gradients between those from a higher social those from higher social group and those that are actually at the lower part of the social system. So you will need to look at health indicators for the health status, indicators that actually examine the major determinants of health, for example, like healthcare utilization, and other healthcare indicators like how the costs distributions, the resource allocations, and the utilization of different resources are distributed within the population. Then the last 3, next slide, aspects of an equity measurement strategy is identifying the appropriate data source for good information, because one of the most difficult challenges of the equity measurement strategy is really having that consistent good data that will permit you to analyze to capture these differences within the population. And This data generally comes in from surveys. You can actually have like patient experience surveys, provider experience surveys, organizational assessment surveys, or household surveys, and some studies actually use census data that's collected at a national level in order to carry out this analysis. Then administrative and clinical data also need to be collected appropriately. Then after that, you need to describe the different patterns of health inequalities. This you can actually do some sort of like segmentation and some certified summaries that would identify like different groups or subgroups within your population that share the same characteristics, or also some sophisticated statistic approaches that will help you to analyze the way or like describe different patterns of disparities within your population. And then at the end, you also need to have a practical impact on, okay, now we understand these different disparities, what next? So you need to consider what are the implications of these disparities within like at the policy or practice level, and also to develop some sort of plan that will help to address or to redress these different inequalities. So thank you. I think we'll go next to Walters. Yeah.
Yes, thanks, Paul, for that overview. And some of the people are starting to come in, many of our participants on the chat with their activities and the ways that they are engaging and sharing information back and forth. It's such a pleasure to see that that coming together and sharing learnings across, and that's really a lot of what today is about. So we're going to ask a few questions. I popped into the chat. We're interested in what you're interested in equity, and we're also interested in how. So here's the what question. What indicators or what domains or aspects, and I'll ask our team to help with the poll here again, are you interested in consideration as it relates to equity? Again, we have here the quadruple aim. We've slightly separated out health utilization, healthcare costs, because sometimes it's a bit of a proxy outcome, sometimes it's a cost element. So left it on its own a little bit, but think about which aspects and that you're considering right now. Not like eventually we need to consider all of these, but I'm interested in which ones that you are currently most interested in as it relates to equity. And this will be an interesting poll as people are chiming in. We think that, as I said in the beginning, we should be considering equity in each one of these, and I'll go through some of the ways that we're doing it. We don't do it the same across all of these. So all of the above. Yes, that emphasis. Maybe we'll leave it open for about 5 more seconds. Still a few people clicking in their last options. I think we have a pretty good sampling of what people are interested in. So maybe we could post this and we could all have a look and see what the results are. So number 1 on the list, patient experience. Number 2, health outcomes. And number 3, utilization. And I think, yes, it does depend on where the equity data is available. Thanks for that, Aideen. And provider experience less so, although actually we do know that some OHTs are doing that work. Others be interested to know in the chat what other areas you might have a specific focus. Somebody earlier mentioned digital health. That's not obviously related here. So I think that's actually also a very important and interesting element. So keep sharing that. And I think what we're going to do from here is, and we can take down the poll, what we're going to do from here is go into some of the ways that, that we have already collected and shared out in various forms equity-oriented data. And I'll really have to thank Anusha on our team who went through all of our past slides and came back with me with over 100 slides where we talked about equity in the course of our previous events. And I've honed it down here to about just under 20 that allow us to kind of get a little bit of a flavor of the ways that we could do it. And I think many of the ways that you can be doing it as well. So, just to step into this, the first piece is that, when we think about Ontario Health Teams and the mandate for Ontario Health Teams around population health and integrated care, population health and improving value really means both the health of the population and equity. and I've skipped the slide, but maybe you can imagine it. I'm sure it's going to be up in the next couple of events, where we think about population health, and what we need to do is both shift the curve and improve population health, and also squeeze the curve, which means that we are bringing the different ends together by bringing up those people at the lower ends of the strategy. And I think there's a new strategy in the NHS called 25, where they're focused on the 20% of the population, that bottom quintile, and improving care. And I think in the next few months, we'll bring some people in from the NHS to talk about some of the work that they are doing. So that really is both the need to improve the overall health and equity. And here's our quadruple aim, framework as we talked about it. And we talk here about how are we measuring these pieces. So we have surveys for patient experience and also for provider experience. And we're also collecting some patient-reported outcome measures in that survey, and using improvement indicators, mostly based on health admin data. And then also our improvement indicators look at cost containment. And equity, we said, should be measured and as appropriate to each quadrant. So let's talk a little bit about how we're doing this. One of the spaces is to say that patient experience measures are analyzed using individual social demographics and social determinants of health. And I'll show how that is. But because we are collecting data right from the own individuals, we can have that information. We can ask them things about themselves. And I think it can be quite enlightening when we do that. Much of our work at the HSPN is based on health administrative data. And we have both patient and system measures that are analyzed and reported primarily by neighborhood material deprivation. I'll describe that again in a little bit more detail. And we have both OHT level analyses where we show improvement indicators according to the degree of material deprivation in the OHT, but also to each OHT, we've been sending data back. And in that data, for all of our indicators, we let you know what the what this performance or the improvement ratings are for each quintile of material deprivation. And then provide experience measures, we also have that individual sociodemographics approach. So when we have the individual sociodemographics, coming back to that equal opportunity for individuals to attain their full potential health, these are some of the things that are both non-modifiable and modifiable. So some of the non-modifiable ones being age, sex, and race and ethnicity, and then ones that might be somewhat modifiable around food, housing, and income insecurity. I would say social isolation is hopefully modifiable. Rurality, and then according to what people's health needs are. So we want to make sure that people are getting equitable access to care depending across their health needs, particularly important in the health space. So here are some of those that are measured. So this is about just under 4,000 people that had responded to the HSPN OHT patient survey. We have this available for use in all OHTs. And here are the numbers. So when we looked at it, about 70% of people said they had no difficulty paying bills. Another, say 15% or so said that they rarely, but then we have these people that sometimes, and a few people always, are having difficulty paying their bills out of the Ontario Health Team population. And this isn't through any concerted effort to target people who might be in lower socioeconomic groups. This is just in a general population of OHT respondents who went on, clicked into our computers, and answered the surveys. Were they worried about losing housing and enough money left for food? So those three pieces. And then over on the right side, we have social isolation. This is out of the Stanford measure of social isolation, where we talk about feeling isolated, feeling left out, and lacking companionship. They're similar and related, but they are a little bit independent. So these are some of the ways. We also have gender and sex and some of the and race and ethnicity, and we'll see some of those results a little bit later. Material deprivation. This is one of the indices that's available through the Ontario Marginalization Index. It's an area level measure based on census data. There are 4 components to the overall marginalization index: residential instability or housing insecurity, ethnic concentration, which is both recent immigrants and or visible minorities, the dependency, which is about the portion of the population that are not working versus the ones that are working. And then here is this space in the material deprivation, which we focus on and think it's probably the best of the indices in terms of its comprehensiveness and in different ways. So it includes aspects related to income, education, family structures, housing quality, as well as the ability to access and maintain basic needs. It has a close connection to poverty, and it has been linked to poor health outcomes. And you'll see this both in our work, and also we've done some comparative work with England using material deprivation. They actually fund organizations with an adjustment factor for their social deprivation index, which is very similar to this one. So here, some of the people have seen this exact one or previous iterations of this. We now have all 50 teams here. And here what we have is the proportion of the population in each of the Ontario Health teams finds itself with a population in each quintile of that material deprivation. So down at the bottom, we see one of the OHTs that has 50% of their population are in the least deprived or the highest SES group, and only about less than 10% of that OHT has its population in the most deprived quintile. But if we look up at the very top of the chart, there's an OHT where almost 40% of their population are living in the most deprived quintiles, most marginalized, and less than only about 10% of their population living in the least deprived areas. So quite a bit of variation across the Ontario Health teams, and this just deals with the population that you need to address and mitigate. So here, let's start looking into some of the data. I just want to give you a little bit of a flavor of what some of the population demographics are for Ontario Health teams. And now here are some of the areas from the patient survey. And this is we have the 6 attributes of patient-centered care that are up top. And then we have other measures, including health services, transitions, as well as these highlighted at the bottom, some of the measures that we're interested in as it relates to equity. So I'm going to look at not the entire survey, but just a couple. So here's on the left, difficulty paying bills at the month, and on the right, feeling isolated from others, just 2 of the dimensions that we might be considering in equity. And we're measuring here whether the time that they had to access a usual provider, how acceptable that was, like much too long, somewhat too long, or about right. And we see here some not major, but minor gradients according to whether people have difficulty paying their bills, and those who always have difficulty paying their bills seem to have the most difficulty in accessing a provider. I can't explain exactly why that is, but it's appears to be true, with less than 5% of the people who never have difficulty paying bills and more than 20% of the people who always have difficulty paying bills having that access challenges. Maybe it's an hours issue, maybe it's a time, maybe it's just a navigation issue, but it's clearly a bit of a gradient. And when we look at the feeling isolated from others, again, we see another gradient here. And this is just in terms of timely access, the first thing that people need to do. Once people have accessed care, what about their confidence that the healthcare provider will check up to ensure that their needs are being met? And what's the level of confidence that people have? You see that this varies a little bit across whether people can pay bills at the end of the month, a little bit of a gradient, not too strong, but it's there. But feeling isolated, especially when you get into that population that always feeling isolated from others, they are having much more difficulty in having confidence that someone's actually checking up on them. And that's probably tightly related. If no one's checking up, they're feeling more isolated. So this is just a couple of the ways that we're looking at those patient experience measures out of the survey and looking at them across these stratifications being the simplest way. And we're going to talk in the future webinars about more sophisticated ways, but just simple stratifications to get a sense. Also looking through the indicators, we thought maybe there's 2 here. You could put these in different buckets, but they might be proxy measures for patient experience. One is whether people are needing to access mental health. Is that in the emergency department first? And actually the interesting thing here is that so this graphic here, we've shown these before, but I'll pause because people may not quite remember them. This is the total number of people in each of these bars where they access the emergency department for a mental health and addictions issue across the province of Ontario, stratified by which material deprivation quintile the individual comes from. The blue meant that they'd already had contact with the healthcare system, and the green means that this is their first contact. So we see here that actually the proportion in the green bars doesn't vary massively across the different material deprivation quintiles. What we do see here is that the people in the area of greatest deprivation access the emergency department a lot more than anybody else. But I would say this isn't a very strong gradient. So everything is not always strong. And here's another one actually that is not super strong. Deaths in hospital are not very strongly related to material deprivation either. In this graphic, we're showing the proportion of the population that die, proportion of deaths that happen in a hospital for each of the OHTs. And the OHTs are colored by the proportion of the population that are living in the most deprived areas. So the darkest blue are the OHTs in the top quintile with the most deprived patients. And you see they actually appear all the way across here from relatively low deaths on the far left side to high numbers of proportions of deaths in hospitals. You can find this on our end-of-life specialty report on our website. So what about patient outcomes? So here again, we're going to start with the patient-reported outcomes first, and then we're going to have these more population ones. So here, this is overall self-rated health, fair to poor, good or very good and excellent, according to difficulty in paying bills at the end of the month. You can see a very clear gradient here that as people have more difficulty paying bills, they are definitely less likely to be excellent or very good, more likely to be in poor health. And again here, this is around whether people felt isolated. That's now the stratifications across the bottom. And again, we see quite strong health relationships according to those people isolated. And then we have it for mental health, even stronger gradients when we're considering mental health outcomes for people. And I'm just using these two examples to let people just have a sense of how strong some of these relationships actually are. They're quite remarkable. And I know that this has changed my view on noting about social isolation as really being an important social determinant of health. And this is some of the first data we've actually been able to really pinpoint. Looking at the hardest outcome we have, which is premature mortality, this is this sort of one of the strongest measures. It is very strongly, the tau correlation here is 0.5, which is very strong relationship between premature mortality and the proportion of the population that are living in the most deprived areas. It's a very striking figure. And we also have shown to OHTs what the differences are within OHTs. I didn't put it up here, but very often within an OHT, and we've shared these results out with each OHT, it is more than twofold that the premature mortality rates in the most deprived neighborhoods are more than 2 times higher than they are in the least deprived neighborhoods. It is quite something. But even here, then we also have changes in activities of daily living long scores. These are functional measures for the frail older adults. This graph is shown in our older adults report. And here we actually don't see a very strong relationship. It's relatively weak, and it's actually inversely correlated with the people are having more declines when they are in the groups that have the less deprived neighborhoods. So again, needing to look at each one individually and consider what some of the drivers might be. We have a couple of measures here around cost. I'm working my way around the quintuple aim, the quadruple aim, sorry, and the correlation here with total cost is also relatively high. A strong correlation with deprivation. We see most of the OHTs that have higher costs also have more people living in the more deprived neighborhoods. And that's the challenge they have to face, is how do we manage that? Moving last step here in our walk around the quadruple aim is provider experience. And I'm going to show here just one of the areas, I think, across 2 dimensions, or 2 of the areas, 2 of the indicators. This is our provider experience survey. The data I'm showing here come from one of 4 OHTs that have launched this, and we have about 400 and something odd surveys now in the area of provider experience. More OHTs are adopting it. And we don't have all the data. I actually came across an OHT the other day that had adopted particular items out of this survey for use, and you're free to do that too. It's available on our website, but we can also provide some support internally with an online resource for you to complete the surveys amongst your staff if you want. But here we see, whether people had an opportunity to contribute to major strategic decisions according to age, race and ethnicity. It's a bit of a combined category. And then also by gender. That's man, woman, and prefer not to respond, prefer not to answer. They're showing, and you can see that they are not linear relationships. These don't have clear, sometimes they're very categorical, and I haven't outlined these up in any ordering at this point in time, but to show some variation. And I'll say that the sample sizes in our race and ethnicity groups are still relatively small, given the respondent populations that have answered so far. I think we're about 80% white in the responses, but there's still substantial and enough in here to have people represented in pretty well each one of the response categories. And then this is a question around burnout. We hear a lot about burnout, and so we have this item around whether people how they best describe their situation at work. Enjoying their work is in the blue at the very top, and feeling completely burned out in the red at the bottom. And symptoms of burnout not going away being in the orange. So the kind of orange-red might be the areas we're most concerned about. And I'll say, like, when we look at age, it's the earlier age, 35 to 49, those are the people that are feeling the most burnt out. The younger and the older, and presumably the ones that are 65 and older have a lot more autonomy. They also had better ability to make decisions in their work. So those individuals, the ones that are still working, seem to be having a better time of it. And then we also see going across by race and ethnicity and gender. So these can be, dependent upon what your OHT is. Really looking at it within that lens is going to be the piece. This is just provincial data across all the OHTs, but OHTs themselves that have conducted this being able to do that. So, I'm really interested. Not very good at talking and paying attention to the chat, but I'll come back to do a lot more chat. But some of the takeaways here is that first off, there's considerable variation across Ontario health teams in the distribution of the attributable population in the areas of low to high material deprivation. Every OHT is not facing the same population. The equity measures in the patient surveys are also showing some important issues related to the social determinants of health, and particularly also social isolation. The equity measures in the provider surveys are a little less striking, but smaller sample sizes means we still have relatively little information. And so I'd encourage us to continue to pursue this. And within OHTs, we are happy to support our provider survey through the online tool that we have made available through REDCap as well. So it is a secure environment. And we have from our website ways that you can go in and look at the provider patient surveys and think about how you can collect that information individually. Some of our kind of key takeaways here are that social determinants of health are substantial and they are statistically related to patient-reported experience and outcomes in that survey. So we need to be cognizant of this. And so today, our starting point is measurement, and we're just saying that's what our measurement is telling us. Some of the measurement proxy measures that we have, like maybe ED first, they have less association. Some of them do, but not all of them. And then the measures of health outcomes, such as premature mortality, tend to have higher associations with area level deprivation, and that lines up also with the patient-reported outcome measures. Healthcare cost itself was moderately to strongly related to area level deprivation, meaning that if you have more deprived neighborhoods, it's costing more to care for those people. I think there's two things to think about there. One is continuing to meet those needs because they're higher needs patients. But the other thing is also, like, what are the other determinants that aren't healthcare that are affecting those individuals and then their health-seeking behavior as they have greater needs? And that's, I think, where we really want to get the conversation to as we evolve over the next couple of webinars and, over the future of Ontario health teams. And finally, just our provider experience has some, but relatively in our sample so far, variable associations with individual sociodemographic measures across the different groups. Okay, so back to you. And now I'm interested in knowing what dimensions are you using to assess equity? So if we could go out to the poll, and this will allow me an opportunity to start catching up on some of the chat here as well. So which dimensions are you using to assess equity? Are you contrasting your measures by material deprivation, income security, social isolation, and it looks like I didn't have a box here for other, but if you have an others areas that you're looking at, if you could put those in the chat box, I'd be very, very keen to allow us to start to kind of carry out our approaches here. So keep coming in, and we're very interested whether you have data, whether you're starting to actually measure equity, and if you are, what are the areas are you using to start to look at equity? Okay, so there are a couple of comments in here. Actually, quite a few. Yeah, so where do I start? Okay, I'm going to pick it up somewhere along the line with Ivan's comment in here. Be interested to know the impact of on economic and societal effects of digitization. Yeah, so the other thing our patient survey has in it is use of digital health or apps and how much people are doing that. And I haven't looked here, and in fact, I'm not even sure we've looked yet to those respondents to see if there are equity differentials in people's use of digital health applications. But people are responding in that survey about how they're using digital health, and then we also have the equity measures. So we can come back and look at that a little bit. Yeah, some people definitely using the on-march, and I would suggest that not to use the aggregate on-march, that you can use the 4 quadrants. We really focus on the material deprivation, and most of the people that are working in this from an academic perspective are using that indicator, that tool, and we can have discussions about what each of the quadrant tells us, but that seems to be a little bit one of the more useful ones, but certainly not to use the overall index, which confounds many different things, all of which are not moving in the same direction. Our surveys, Deborah, are digital at this point in time, but other places have used them where they've actually had paper. You can create a paper-based version and then have people enter them. We at present don't have resources to support paper entry ourselves, but if we have enough demand, we might be able to turn something into a Scantron or something. But for now, we're doing digital. There are many ways that marginalized populations are not going to complete the surveys. Biasing results, absolutely true. Moreover, surveys are not the only way to collect information about patient experience, nor are they the only way to collect information about deprivation or other social determinants. And so we really need to be taking a multifaceted approach, both to collecting the data and interpreting the data. I want to come back to one of the earliest comments around community engagement. I think that's really where I would encourage OHTs to begin a lot of their journey. They're early implementer of data governance, engagement governance, access and protection, EGAP. I strongly encourage people to be thinking about both EGAP and OCAP, the indigenous principles of ownership, that you're really considering these in everything that you do and collaborating with people in how you're sharing that information. Trudy, yeah, glad to see that you guys are looking at digital literacy as well. Why don't we come up to the poll results and then share those out, and then I'll come back to some more of the chats. Let's have a look here. How do we do? So income level, race and ethnicity are at the very top of the list, very closely followed by material deprivation. I think that is generally should be available to most OHTs through various data sources. I know that the work that Wendy Jerry's group is doing, they provide it, and they've looked at it in many ways. I think it's available through IntelliHealth as well. The housing insecurity being none, and so also these are areas that we've put out, but they're not universal. Different people are doing different things, as I can see from the responses here. We can take that down now, and let me come back to the chat. And really keen and interested on some of these. I'm going to keep going through the chat, but just before I do, as people are entering and putting comments in, we're interested in these kind of 3 questions. One is, how are you building capacity to measure and address equity? A second is, are you measuring equity and how? And we just talked about some of those. And some of the polls have given us information on there. And then the last one here is, have you designed any interventions or any approaches to begin to address inequities in health, and how? And I think these are just really valuable sharing across OHTs, everybody here. So one of the ways I see Leslie Wells and the Ottawa Health team looking at ways to support partner organizations to collect more and higher quality sociodemographic data. So, I'd call that both an intervention and building capacity and measurement. So that's something that's actually all three, because we're doing the engagement, and the intervention is actually to start to collect the data and allow more data points to be disaggregated. So appreciate that approach. Not through the OHT, but at an organization level, Tara Neckmeyer talks about informing our client-facing survey through guidance from family advocates, inclusion, diversity, equity, and accessibility. Some other care metrics, including language. Yes, absolutely, another dimension. So thanks for raising these. Transportation, family structure, disability status, and the analysis to focus on the intersection of identities. If one of our participants, I'm sure I saw Grace on here introducing herself earlier, one of the OHT Impact Fellows, really interested in this space and the importance of intersectionality in these areas as it relates to equity. So it is not just one thing on its own, but these things actually tend to cluster and amplify and magnify each other. So that's really interesting. And Usman talking about exploring ways to support primary care providers with reports for equity deserving communities. Again, using local tools, and for example, EMRs, and Paul had mentioned EMRs as one of the data sources. And increasingly, we really need to make sure that we have race and ethnicity and language being captured in our EMRs and being used. CWOHT had 4 sessions for its leadership focusing on equity. I think that's excellent. And those conversations, you need to have it at the leadership level. They need to have it throughout the organization, and they need to be continuous, ongoing, and repeated. That it's not one, and it needs to always be on the board. And it really is, there are individual aspects related to addressing equity, but there are also very much structural and systematic aspects to even be aware of the different ways that equity is presenting itself. Equity-based initiated a collection of equity-based data and programs being launched now up in CW. So great to hear. Working with some smaller service organizations, Helen Lung says, that don't have resources to serve their communities. And I think that's understanding how do we support each other in this work. And Paul will be on with some of the OHTs in one of our upcoming sessions and talking about how they are building capacity across many of their organizations, large and small, and supporting that work. So we're interested here to learn about what you're doing. Also, count on yourselves possibly getting a call from us, as we want to take it down a level other than the chat comments here of what you're doing, because we're really interested in sharing. And I noticed very early on in this today, many people were talking about getting each other's information about terms of reference. We really want to help people start to advance their work, and what gets measured is really important to help do that. And the Health System Performance Network, our interest is in using data and measurement to advance the equity agenda. And then it's really up to you and your ways, but to engage with communities and make the interventions happen. But we're hoping to support you in doing that by helping to understand how you can have data support that work. Northwestern OHT, Tiffany tells us that getting the OHT partners to complete a comprehensive assessment, provide a benchmark of where partners are at along their health equity journey, and looking specifically at racial equity. And so I really admire that. Middlesex London creating collaboratives with the agencies that have the resources can share with those that have less. Really, really nice to see that. And again, now people are putting out information and putting out links. I think today when we put out our slides, we will make sure that we add a slide to the end with the resources from people that have shared in this webinar so that they'll be available to everybody after the event. So we will, again, this is, today's event is really a lot about this joining up and allowing us. So knowing how you're building capacity, how you're measuring equity, and how you're designing interventions. Maybe I'll drop the slides and Paul and I will maybe discuss some of these opportunities. And Paul, if you're available, probably come up, because I know that you have been doing some work specifically. Please keep the chats coming. But Paul, you've been doing some work specifically in learning what some of the Ontario Health teams are doing in terms of capacity building, and maybe a little bit of a preview of some of the work that we'll be presenting in the upcoming webinars related to this, so people can think about that in their heads and what they might be doing that might also be very valuable. We can certainly see the sharing. Paul, what are you finding out?
Yeah, I think, and in fact, we really want to invite OHTs to share their experiences, because we are in a real learning curve. We're trying to understand exactly what are people actually doing in the field, what are the challenges they face, and what are like the opportunities that they're actually leveraging in order to advance the equity work. So yeah, I've been also like embedded in like one of the equity work groups, and seeing how they're actually developing their activities and how they are progressing in their equity work. And what I'm actually seeing is that they start small, focus on one aspect of equity, and actually when they build like capacity to work on that particular aspect, like they were work group I was embedded in basically focused on anti-Black racism, and so they kind of like hired different personnel that had experience in this particular aspect of anti-Black racism. Then they carried out some organizational survey within their Ontario Health teams, the different partners who collaboratively work together in their Ontario Health team. And at the end of the survey, they presented the results down to all of the different partners. But the challenge was mostly, after having these results, collective results, what do you do with these results? Are you going to like act as one coherent team, Ontario Health team, or do the different organizations themselves actually had to look within like that, okay, what are my results within the broader OHT results, and how do I actually use these results to change practices like anti-Black racism practices within my organization? So one of the interventions that was carried on was mostly like the leadership training, sensitization, and awareness in like in terms of anti-Black racism. So and where the team actually is now is like having really worked, like build up that kind of trust within the different team members, the group. Now they actually trying to scale up their activities, maybe towards covering other aspects of equity, including maybe like gender and so on and so forth. So yeah, that has been my experience in terms of observing equity work within some teams, and hopefully we will have maybe much more this OHTs presenting the evolution of their work in future webinars. And we're also calling on you, if you have like interesting things that you're actually doing in terms of interventions you're developing, or measurements strategies, or different aspects of measurements that you're actually carrying out in your OHTs, to contact us, and so that we can share your story and learn from you, and also you can also learn from the other Ontario Health teams.
Yeah, and put them in the chat here. We'll be going back through, but I'll also reach out. We are very interested, because we know that this is it's a challenging area. And I just popped a question into the chat for people to respond to ask about what do you see as some of the biggest challenges to address equity gaps in your OHT that you're finding. So one, it might even just be measuring and identifying the gaps might be the biggest challenge at the outset. But even once you've done that, thinking about how you'll bring the right partners in and how you engage with communities to be able to do that well, may be another challenge. Another challenge that came up in a conversation I was having the other day with a few of the OHTs was that many times when we're solving problems, we're like, we have 80% of the problem solved, that's good enough. And actually, the last 20% of the problem is the equity gap. And that the people that present themselves, and people talked about this in digital early on in the chat, I saw people who answer the surveys that we put out, people who respond to the phone calls, that may be 80% of the population, but that's not the 20% that are in the quintile 5 of the most deprived or the most racialized or the otherwise inequitably able to access health and care, that is the tail. And that really needs to be the focus, and getting through, if we move 80% of the population, we are not addressing equity. Looking at some of the last few pieces, wondering about the structures of QI and specifically lean models. Can they address inequity when they've traditionally missed the most vulnerable populations systematically often? And it's interesting because sometimes the people who are targeted or identified to participate in those, and the ways we go about undertaking some of those QI activities are, again, about getting the bulk of that population. You know, Paul, you started into doing some work and looking at the literature as it related to integrated care, right? And whether integrated care programs, and I know you're not finished that work by any stretch, but you know, were you finding, was it easy to find integrated care initiatives that would be addressing equity and how they were addressing equity?
In fact, so when we tried to carry out this review, it was really difficult to actually identify integrated care programs, that is, these collaborative models that jointly developed interventions to address equity within the health areas where they have these joint responsibilities for the population. So that is some, I would say, a practice gap that we really need to explore more and find ways to help people, I mean, like these collaborative models, to work towards equity as a group instead of individual organizations.
Yeah. And that's very interesting. And I think I saw a comment in here about different people from Helen, yes, discrepancy interpreting defining equity among the OHT members. So even across different organizations or even members within an organization. So part of our thinking here too is also to give you some tools, maybe through some of the definitions, for you to have discussions within your OHTs about what equity means and come to some consensus and variations in defining marginalizations within the populations. And this is not unidimensional, this is multidimensional, and there's an intersectionality to it too. But I think, you know, maybe to have some conversations and to start and to say, as Paul said, you know, we have an equity agenda and we maybe have an anti-racism agenda, and we're going to start with anti-Black racism. That kind of breaking it down. That's not the only problem. That's not the problem we're trying to solve, but this is where we start the work. And I think that's a pretty practical, pragmatic approach. And I think that's a good thing to do. The conversation a little bit between Leslie and True equity work taking time, and Trudy agreeing with Leslie on this. You know, very often, you know, the people that aren't accessing care aren't interested in answering the HSPN survey. You know, that's an example. Who are you to me? And who are the providers that have recommended I complete this survey? And trust is massive. Trust is massive. People won't even talk about gaps in care or come forward and self-identify or participate even in community events. And I think that is working with those individuals who are willing to make the bridge from within the communities and allowing those ambassadors to work, I think, is one of the ways that OHTs have worked. Even through the pandemic, that was certainly an issue, and the community ambassador work that ensued out of there. So there are ways, there are not instant fixes, but I think they're really important in terms of getting out there and being able to represent and being part of understanding and building those bridges to the communities over time. So I think that's probably a lot of discussion about our intro here. And I'm just going to let folks know that we do have a couple events coming up related to equity. And I do hope that you found today to be somewhat useful. So I'm going to come back, let people know a little bit about what's coming up. If I can get to the right spot, I think I can here. So first off, just up that this webinar series happens the fourth Tuesday of the month. It should be in your calendars. And today we titled this around measurement of equity and being a primer. Is one, we want to get a bit of a pulse on what's happening across Ontario health teams. We found some things. We will be reaching out to some people. Also very interested to have you contact us. HSPN@utoronto.ca, or you can find us on through our website. Feel free, really do contact us and let us know what you're doing. Questions you have for other Ontario health teams, contact us. We'll bring these up. We see the series evolving in three parts over the next few months. One is building capacity, the second is measuring, and the third is addressing inequities in some of the program ideas. So I think that it'll be really, really, really helpful to have these. We did have one more poll on whether people had accessed, could make use of today in their work, and I was interested if there was a we can bring up the poll on I just get the right title for the people's use of today's information for our team. We can launch that poll. Be interested to know. Nope, that's the knowledge about today's topic. One back from there. You can take that one down. Yeah. One back. It was use of information. Maybe it needs me to do this. I don't think so. Oh, there it is. Perfect. How much of today's? You don't have to answer honestly, right? We're trying to design and tweak, and this is one of the ways that we can get to know a little bit about the use of today's information. Bring it right in as a poll. Okay, I think we have most of the people that are going to respond to this have responded at this point, so we can probably end and close it up, pop it up as a result. And I say that's pretty good. So about 42 saying quite a bit, 39% saying some. And about 20% saying a little, and we appear not to have wasted anybody's time, at least amongst those people who are still here with us today, which is well over 100. Last piece is on being able to share some feedback. You could scan here. I think it works. Did when I did a little test yesterday, so hopefully it still does. Let's see. And that'll bring you over to like a little 3-item questionnaire that we have. And we could probably pop an example of the link in the chat as well for people, possibly as well. A few of us are experts here, but not many. Most of us are on a journey. And I just want to appreciate everybody today for coming, sharing what you know. And I think all of this is going to be an important topic for us to continue to address. We are not going to solve equity issues in the next 3 months, but we're going to raise them and share and talk about some of the ways that people can contribute to the conversation. So appreciate everybody for joining us today. And again, letting you know this is how you can contact us. This video and the links will be added to the slides, and that will be posted on our website, hopefully by the end of the week. Usually we're always within a week, sometimes within the same week, and appreciate your joining us today. Thank you. Do provide us a bit of feedback. It's hard to get feedback from the audience. I know you keep coming, so it tells me we're doing something useful, but we're also trying to get more specific feedback on how we do these and what else we can be doing to help support your work in the OHTs. Well, thank you very much again for joining us today, and I hope you all have a great afternoon.